Welcome everybody to today's webinar on the topic of advances and current status of living donor liver transplantation in the U.S. We have a fantastic webinar for you and two really superb speakers, and we're really excited about this topic. And just before I introduce our moderator to introduce our speakers, I want to go over a couple of housekeeping items. And I also just want to introduce myself briefly. My name is Heidi Aguirre, and I'm a member of the Alliance team. So in terms of if you're the first time joining us on this webinar for using this platform, if you have questions for the speakers, you can submit them at any time. During the webinar, we will be holding them till the end. But if you want to submit questions, if you look at the bottom left-hand corner, you should see a blue icon. Just click on that and type in your question. We are recording this webinar, so we will not be unmuting the lines. So that's the only way you can submit questions. Also, I wanted to announce coming up on April 11th is our next donation-focused webinar, also called the Get Connected webinar series. And this topic is on technologies in organ donation management, utilizing technology to become more efficient and cost-effective. And registration is open for that. Also for today's webinar, we are offering 1 SEPC credit, or also nursing contact hours, 1.2 nursing contact hours, courtesy of Iowa Donor Network. So in order for you to receive these certificates, everybody has to complete an evaluation. So for those of you who registered the group for the webinar, you will be receiving the evaluation email. Please make sure to take note of everyone who's in the room with you if you're hosting a group, and forward that email to everyone in the room so that everyone can receive their certificates. Please note that for sepsis you have 30 days, but for nursing you only have 14 days, so please make sure to submit your evaluation for your credits within 14 days, and that's not business days, those are actual 14 days. So at this stage I would like to introduce our moderator for today. Our moderator is Travis Watson. He's a member of our Transplant webinar faculty and also the Transplant Administrator at UPMC Presbyterian in Pittsburgh, Pennsylvania. Travis, thank you so much for coordinating everything, and I'll turn it to you. And maybe you're on mute. Travis.
Thank you, Heidi, for the kind introduction. This marks 10 years that Heidi and I have been working together, and it's always an honor to be part of the Alliance projects and presentations. For today's presentations, I am fortunate to work with and introduce two of the leading experts in living donor liver transplantation. Dr. Abhinav Humar will be presenting the first half of today's presentation. Dr. Humar is the Thomas E. Starzl Professor in Transplantation Surgery, the Clinical Director of Thomas E. Starzl Transplantation Institute, and the Division Chief of Transplant Surgery here at the University of Pittsburgh Medical Center. He oversees all clinical and clinical research activities at one of the world's most active and prestigious transplant programs. Dr. Humar's areas of interest include partial liver transplants, studies of hepatic regeneration, clinical outcomes in kidney, liver, and pancreas transplants, cytomegalovirus disease in transplant recipients, and outcomes in pediatric kidney and liver transplants. His research pursuits have resulted in numerous National Institutes of Health and multi-year pharmaceutical grants. He has had more than 400 abstracts accepted at national and international transplant meetings. In addition, he has authored or co-authored more than 170 manuscripts, 20 book chapters, and 2 books. Dr. Humar received his medical degree from the University of Ottawa, where he completed his general surgery residency and later a cardiothoracic surgical fellowship. Dr. Humar also completed a surgical fellowship in transplantation at the University of Minnesota. Dr. Swaytha Ganesh will present the second half of today's presentation. Dr. Ganesh is the Medical Director of the Living Donor Liver Transplant Program here at the Thomas E. Starzl Institute of Transplant at University of Pittsburgh Medical Center. Dr. Ganesh attended medical school in India and completed her residency in internal medicine here at UPMC. She then completed her fellowship in GI and transplant hepatology at UPMC as well. Her areas of specific interest include decreasing waitlist mortality, improving transplant recipient outcomes, and the pre- and post-donation care of living liver donors. So at this point, I will turn it over to Dr. Humar.
Thank you very much, Travis, and I'd like to thank the organizers for this opportunity to speak about this topic. So what we'd like to do over the next 40-50 minutes or so is talk about live donor liver transplant, what it is, what the advantages are, what the benefits are, what some of the problems with it are, and where it can be best utilized. And we've essentially divided the talk up into two main areas. I'm going to concentrate mostly on the donor aspect of it and look at it more from the donor's perspective, and my colleague Dr. Ganesh is going to look at it more from the recipient aspect and talk about that, though there will be some overlap between the two. So what exactly is live donor liver transplant? As many of you know, live donor liver transplant, similar to kidney transplant, is just utilizing a part of a healthy donor's liver for the transplant, and there are several reasons we can do this with the liver. So I'll just start by, I have no financial disclosures related to this presentation. Okay, so there are many advantages to live donor liver transplant, and I've kind of listed them here, as well as the disadvantages. The main advantages to me are listed at the top, which essentially is the ability to decrease waitlist mortality, as well as waitlist time, and the ability to transplant a patient before they become critically ill with a very high MELD score. It converts a emergent operation into an elective one, thus allowing for the best preparation of the potential recipient. There's probably some immunologic advantage, and it adds to the overall pool of livers. And as well, there's probably some financial benefit, especially if you look into the ability to transplant patients earlier on in their disease process. There are obviously disadvantages, and for the recipient, there are not really very many, but there are some in that it is a bit more technically involved, so there's a higher incidence of bile duct and vascular complications, and there is initially some decreased hepatic reserve. But really, what it boils down to are the short-term and the long-term risks to the donor. And as you see on this scale, the way I've drawn it, at least in my mind, the advantages outweigh the disadvantages, but it is really the disadvantages that we have to be most cognizant of. And if you look at the national data with regards to liver transplantation in the U.S., on the left you see the number of transplants. Red represents the total number of transplants. Blue is the deceased donor, and you might have missed it, but the green line at the bottom represents the number of live donor liver transplants in this country, and you can see that it barely registers on the graph. And if you look at the number of centers, this is data from 2013, but you can see that the number of centers that were doing any significant volume of transplants, more than 10, was only 8 at that period of time, and really the other centers that were doing them were doing very small numbers. Now certainly that number has changed a little bit. It reached its peak in 2001, and then unfortunately there was a very highly publicized donor death, and the number of cases decreased subsequently after that. Now it has picked up certainly in the last few years. You can see that over the period of the last 3-4 years, the numbers have certainly increased. And recently there was a report in the AJT, the American Journal of Transplantation, that living donor liver transplant was poised for a comeback in this country, and that in 2015 there was a record number of transplants done, 350 compared to the last few years. And certainly, as I showed in that previous graph, does represent an uptick compared to the previous years. But really, let's put it into perspective. If you look at this compared to some major centers from across the world, especially from some Asian centers, the Asan Medical College, located in South Korea, does over 400 live donor liver transplants a year. There are 2 centers in New Delhi in India that each do over 300 live donor liver transplants a year. These are single centers, and you can see that individually they're doing more live donor liver transplants than the entire U.S. combined. And so certainly, while the numbers have increased in the last few years, they're nowhere near what they are in the rest of the world, and certainly in the Asian countries, which have adopted this procedure much more readily than we have in the U.S. So why have the numbers of transplants remained so low in the United States? There are probably several reasons. It is a complex procedure, and it requires some degree of technical expertise and commitment on standpoint of the institution to commit to having that entire team that can help support it. But certainly there are many centers around the world, and they all need that same technical expertise, and they've been willing to invest into it. So what is it different about the U.S. centers? Well, certainly we have a lot more regulations than most other places. CMS, state regulations, and all of these can have significant consequences for an individual center, especially if there's a bad outcome, especially if there's a bad donor outcome, and those consequences can be quite devastating for a program. Donor complications and certainly especially deaths when they have occurred in donors have been very heavily publicized, and each has had a detrimental impact on the numbers of procedures being done. And unfortunately, risks not only to the center, but the risk to the career of specific team members have been very negatively impacted by these very heavily publicized deaths. So all of those have certainly added to the reasons why the numbers have remained so low. But to me, in my mind, the real reason why it hasn't grown is that people just don't know, or they're misinformed. And by people, I left it at people because it's not just the patients that don't know about this procedure, what it is, what it's capable of, but I find really it's even the medical community, the referring physicians, gastroenterologists, even hepatologists who are not directly involved with transplant or who are not involved in live donor liver programs don't really have a true idea of what it involves, what are the advantages of it, where does it really provide the best benefit for the patient, what are the real risks associated with it. And I think that that's one big part that we still need to do, which is to really inform people in a truthful way about what this involves. Now, there are essentially two main types of or categories of live donor liver transplant, that for the pediatric population and that for an adult. And the reason why I separate those out is that it's a slightly different operation for the donor, but certainly both are done, and we here at UPMC have invested in trying to grow our live donor liver program, and mostly because we've seen a significant increase in our waitlist mortality, as well as our increase in waiting times, as well as the mean MELD scores that we're transplanting at, as many centers across the country have. And I've just shown here the number of transplants that we're doing, separated out by adult as well as our pediatric groups, and you can see that we're somewhere between 20 to 30 transplants. Last year we did about 36 live donor liver transplants. But the key to all of this, and the thing that I'd like to concentrate on, is the donor aspect of it. And donor safety is really the key to this procedure, because we can really, I think, only maximize its utilization, maximize its acceptance, if we can make this as safe as possible for the donor. So really the way to, in my mind, to expand the use of live donor liver transplant is not to forgo or not to expand the criteria of donors that we're doing, but really to be very strict on what donors that we are doing, and to make donor safety the priority in all of this, as all centers do. I'll just go through what our process is. The evaluation of the donor is a key aspect of it, and all donors are seen by 3 teams from our group, medical, a surgical, and a psych team, who evaluate them from each of their different aspects to make sure that they're fit. The medical team sees them to ensure that they're medically fit, and medically fit essentially means that they're in good health. We set the criteria between the ages of 18 to 55, and those are absolutes. We don't do obese donors. We won't evaluate them until they're at least below 33, and won't do the surgery until they're less than 30 on their BMI. They obviously have to be overall healthy, no ongoing substance abuse issues. Those are really the key aspects to the medical evaluation. The donors don't have to be related to the recipient, though often there is a connection, though we've had many altruistic donors. And in fact, they don't really even have to be ABO compatible. It's probably easier to do an ABO incompatible transplant with liver than it is for kidney. And if you look at the national data So this is degree of relation and the donors. You can see that almost half of the live donor liver transplants are from donors that are not at least biologically related to the recipients. They're either fall in the category of spouse, partners, or other, and certainly that's the case that we've seen at our program. We have people from all relationships that come, friends, co-workers, church members, and several altruistic donors that we've done. As I mentioned, they don't necessarily have to be even ABO compatible, though ABO incompatible transplants can be done. They do involve some degree of more technical aspect to them, especially in the preparation of the recipients. This is the protocol that we have in place at our center to do ABO incompatible transplants. The next part of the evaluation is that they should be surgically fit, and that essentially involves a very thorough evaluation of the anatomy of the donor. That's a key aspect of it. We evaluate the hepatic artery, portal vein, hepatic vein, bile duct using imaging, the size of the liver, which is obviously of key importance both for the donor and the recipient, and then possible biopsy if needed. We have a selective criteria for biopsying donors' liver as they need it. We don't biopsy all donors. And with modern imaging, it's really very possible to get a great idea of what you're going to deal with inside the operating room. You can get a good idea of the hepatic veins, the portal veins, hepatic artery, the bile duct, as well as a very good idea of the size of the liver, so you can plan a virtual surgical resection sitting on a computer console and be sure that the portion that you're going to give to the recipient is adequate for them, but more important, make sure that the remnant that you leave behind for the donor is going to be of adequate size for them. And based on that, we can then decide what's the best graft for that individual recipient and tailor the surgery based on both the donor's anatomy as well as the recipient's need, and utilize either a left lateral segment graft if it's a pediatric patient, left lobe graft if it's a smaller adult, especially one that's not very ill, and utilize the right lobe graft for the larger recipients, especially if they have higher MELDs. And then the last component of the evaluation is to make sure that they're psychologically fit, and we have an individual from our psych team that evaluates these patients to make sure that consent is being given on a voluntary basis, that the donor is not being coerced in any way, that they understand the procedure and the risk completely, and they're certainly competent. But also importantly, they assess to make sure that they have the support systems in place and the ability to handle the stress of surgery and the recovery subsequently. So all three components are very important. We bring all three teams together, and ultimately the decision to donate or approve the donor has to be a unanimous one. So all three teams have to approve the donor, and if any one team is not happy with that donor is not approved. So outcomes, when we look at outcomes for donors, because that's really the key aspect of it. Remember, we want a successful outcome, and successful outcome for donor, as with recipients, means that there has to be very close to a zero mortality, that complications have to be acceptable, and that's the standard landmarks we look at when we look at outcomes in recipients. But importantly, on the donor side, we have to remember that these are individuals that are otherwise healthy and are looking to get back to normal quality of life. And so looking at parameters and markers of quality of life outcomes, return to work, return to normal day-to-day functions, those are also very important when we're looking at outcomes in the donors. So what does the national data show? So if you look at the national data for over the last almost 25 plus years that this procedure is being done, there have been close to about 5,000, between 4,000 and 5,000 live donor liver transplants that have been done in this country. That includes all types of grafts, right lobes, left lateral segments. There have been 6 donor deaths reported early post-donation related, most likely directly to the donation process. So if you calculate that, That's roughly about 0.1%. Additionally, there have been 2 donors that themselves required a liver transplant early post-donation that was associated because the remnant liver was not adequate for them. We generally quote for our donors a mortality risk of roughly about 0.5%. That's what the literature and consensus conferences have come up with, but this is what the national statistics show. The overall complication rate on surveys that have been done and pooled analysis that have been done shows roughly a complication rate somewhere between 30 to 40% associated with living donation, though majority of those complications are what we call minor complications, and major complication rate associated with living donation probably in the 5 to 10% range. Now, how does this compare to something that's really very well accepted, which is kidney donation? We do thousands of kidney donors in this country, so this is an interesting analysis that was presented at American Transplant Congress just a few years ago. It was an analysis of the national data looking at all kidney donor deaths within 2 years after the donation. This was between the years of 99 to 2011. You can see that there were 96 deaths within 2 years of donation, and now admittedly many of these were not related to anything due to the donation process, accidents, homicides, etc. But if you look at deaths occurring very early post-donation, which is within the first 3 months after donation, those likely have a higher risk, a higher chance that that's something associated with the donation process. You can see that there have been 25 deaths, kidney donor deaths associated with kidney donation within 3 months of the donor donation, of which 17 were medical in nature. The others weren't, but 17 were medical in nature, and you'd have to presume that that was something related to the surgery itself. Now, also, what about the long-term association of it? Now, we know that the liver regenerates after donation. The kidney does not regenerate, and if you look, there is probably some penalty paid for kidney donation, or at least there is some loss of kidney function, and this was a analysis that was published in the New England Journal that looked at what was the kidney failure risk projected in living kidney donors. And depending on your basic demographics, you can see that there was a slight increase in the projected risk of donors ultimately developing renal failure associated that was above what their risk would have been had they not donated. Now, to date, there have been no cases of late liver failure that have been reported after liver donation, and presumably once the liver regenerates, function is completely restored back to normal. What we quote for our donors is that there's an overall complication rate which is close to about 30%. Majority of these are what we call minor complications, anything that requires minimal to no intervention to get better. But our major complication rate we quote to our donors, that's anything that requires another intervention to fix, another surgery. That's roughly about 5 to 10% depending on the magnitude of the surgery. We generally have a week of recovery in hospital, closer to maybe 5-6 days now. And what we inform them is in terms of recovery, roughly 6 weeks before they can get back to a desk job, 10 to 12 weeks before they get to a manual labor type of job. By 3 months, most donors are roughly by 80-90% back to their pre-donation level of health. Finances are important for donors, as with any living donation, including kidney. Remember, all direct medical costs associated with donation should be covered by the recipient's insurance. Travel and lodging is not covered, but select donors can apply for it for funding through the NELDAC. Lost wages and other expenses are a significant burden on donors. There is push by various transplant societies to have the government provide at least some offset of this, and hopefully these will be approved. But at the present time, these are not, and we often have donors do fundraising or get various financial help from recipients, and that is legal actually, that they can get financial help from recipients to help with this. So I'll just maybe run through very quickly some of the types of transplant. As I mentioned, pediatric transplantation is the way that live donor liver transplant started. This generally involves removal of 25% of a donor's liver volume. There's only ever been one death in a donor associated with left lateral segment donation. That was from a PE. And most of our donors are usually discharged by about 5 days after donation. Some centers are now actually doing this in a laparoscopic manner. And if you look at the outcomes with this, the outcomes are actually very good. In recipients, especially the younger, very young recipients, our national data shows that recipients less than 1 year, the best outcome is with a living donor. The European literature shows something very similar. And yet, if you look in the country, the number of pediatric living donor transplants in the U.S. is actually decreasing. They comprise less than 5% of the total number of transplants. Many centers argue that they just do split transplants and there's no need to do a live donor, but if you actually look at the national data, many intended split grafts end up being reduced grafts, and that the remnant portion of the liver is unfortunately discarded in those situations. Adult live donor liver transplant is where there's probably a greater need at the present time just because of the total number of patients and the higher waitlist mortality, and that's the key thing to remember. There's roughly about, depending on what part of the country you're in, roughly about a 15 to 25% chance of never making it to transplant, and that's what we tell our patients if they're thinking about it. As I said, we try to find the optimal graft for the optimal patient, try to minimize the size of the liver that we're having to remove. We use left lobe grafts for smaller recipients with lower acuity and less portal hypertension, reserve right grafts for larger recipients and with higher MELD scores and more portal hypertension. We don't discriminate. You can pretty much, depending if you choose the graft right, you can do just about any patient with a live donor, and for very very higher risk patients, we do an extended right lobe graft if the donor's anatomy is suitable, because ultimately you want to have a great outcome in the recipient also to balance. And so we follow this paradigm to make sure that we get a technically successful outcome with these grafts. Make sure that we have a good-sized graft with sufficient inflow both on the venous and the hepatic arterial side. Make sure we have excellent outflow and a good bile duct anastomosis, and those are the best things to ensure that we get a technically successful outcome. So I'll stop there and turn it over now to Dr. Ganesh, who's going to talk a little bit more now from the recipient side and touch on some of the things and expand on some of the other things.
Thanks, Dr. Humar, and thanks, Travis. All right. Good afternoon, everyone, and thanks for the opportunity, Haiti, and also Alliance webinar group. And so I know Dr. Humar touched upon the surgical and the donor perspective, and I'm just going to quickly go through why do we talk about living donation and why is it very crucial, and some issues with the liver allocation and the limitations, and the waitlist mortality and MELD limitations and the advantages of the living donor liver transplant. Some overlap, but it's important to talk about it. So why is it very important to talk about living donor? Even though the liver transplant has gone through a rapid evolution over the years, but it's a life-saving procedure for patients with the end-stage liver disease, but there is an ever-increasing disparity between the demands for liver transplant and the supply of the organs. The demand is recently fueled by the increasing waitlist and NASH and hepatitis C epidemic and also increasing HCC. So it is imperative increase the existing donor pool. And how do we increase the donor pool? The options to expand the donor pool includes regenerative medicine, xenotransplants, and 3D printing, but they're not prime yet. And there is no liver replacement therapy like hemodialysis, which is available right now. And some of the other extended criteria grafts and split grafts and domino and donation after cardiac death, some of them are not ideal. Right now, the best and the most effective, safe, proven way and major way to expand donor pool is the living donor liver transplant. So this is the same slide just saying that increasing living donor liver transplant is one of the major ways to increase the existing donor pool. So as you know, some of the issues with the donor allocation, so under the current allocation policy, donor organs are offered to the patients who are at the highest risk of death. And as we know, the NOTA was established in 1984, and 1986 UNOS have been managing OPTN and SRTR. UNOS has allocated deceased donor organs based on MELD score from February 27, 2002, and MELD sodium is the allocation method now. Even with the advent of MELD and MELD sodium for the accurate risk profiling, there is substantial waitlist mortality, as we know. And so what is the burden of the problem? What do we know about the waitlist mortality? Right now, 1 in 7 either die or removed from the list each year. The number of patients who are added to the list keep increasing, and the number of patients who die on the waitlist keep increasing also. However, the number of transplants and the number of living donor transplants do not increase in proportion to the same. So based on the 2015 SRTR data, there were 14,366 listed as of today, and well, probably not today, as of a few days ago when I looked, and 7,335 deceased donor liver transplants in 2015 SRTR data, and only 300 some living donors done. And due to organ shortage, every year around 3,000 lives are lost in U.S. each year. And only around 50% of candidates undergo transplant after 3 years of waiting, and waiting time changes based on several factors, which I'll show you. And only 1.9% of living donor livers. And so overall waitlist mortality in U.S. is 17%, depending on which study you're looking at, and it's around 10 to 28%, depending on the region. And the number of patients who are listed with a low MELD is around 48%, which is 7,000 patients. That's a lot of patients with a low MELD. And there is substantial mortality on the transplant waitlist, which is concerning, and there is a trend towards higher mortality among patients with a low MELD. That is 12% in patients with a MELD less than or equal to 18. And among the patients who got transplant that year, 53.8% of patients were MELD 15 to 29, but only 3.2% of MELD less than 15, as expected, because if you're not high MELD, you're not going to get a liver. And so that's exactly the same thing I'm showing, that if you are low MELD, there is increasing waitlist mortality of the low MELD patients, which is very concerning. And so why is the MELD system? MELD is a great system, right? I mean, it does not work for everyone. It has lots of advantages, but it also has disadvantages. The whole allocation system was built around the MELD sodium, and it is heralded for its objectivity and the success in reducing the waitlist mortality. However, it does not, some aspects of medical urgency is not accurately represented, and it does not account for lots of things, like it underestimates the serum creatinine in women. It does not account for quality of life, fatigue, sarcopenia, does not account for frailty or deconditioning, does not account for ascites, does not account for several things, and approximately 15 to 20% of patients whose survival cannot be accurately predicted by MELD sodium. So you could still have low MELD, sodium, but high risk of death. So what are all the factors involved in allocation policy which affects the patients getting the liver? As you know, geographical location, region, disparity, blood type. If you're blood type O, it affects, and if you're region 2, it takes longer to get a liver. Gender, racial disparity, access to liver transplant is affected, and even depending on where you are, getting to, some patients are from West Virginia, it's difficult to get to liver transplant center. Exception points, MELD sodium score. So the urgency of listing. So several things involved in allocation policy. And so this is one of the slides I want to show, which actually starts with why liver transplant is very beneficial even at a low MELD score. So if you see this, that, thank you. So if you see this, that ability of MELD to predict death does not, the evolution of the MELD score the evolution of the MELD score is important because the MELD does predict mortality on the wait list. However, as the MELD score goes up, the probability of death also goes up. So as you can see, the benefits of the liver transplant is actually more when the MELD score is more than 17. When you see that the hazard ratio is 0.62, as you know that the benefit of liver transplant is much higher when the MELD score is more than 17. So that's also important that you don't wait until 25 of MELD to refer a patient. You can start referring when there is decompensation or when the MELD score is 15, or you don't have to wait when the patient has liver disease, irrespective of the MELD, when they have decompensation, you can start referring them. Just one slide on geographic disparity. It does exist, and it's higher rates of transplant in the southern portion of the nation, and there is threefold difference in the proportions. And as you know, there is 11 regions with the 58 OPOs, and this is the graph. Sorry, this is the map which shows that. And then there is 84.84% around these regions where there is highest rate of transplant, and 28.2 around these regions where there is lower rate of transplant. So this is one other slide which shows that this is exactly the reason why we want patients to be referred. When you have compensated cirrhosis, they can live for at least 10 to 12 years. But when you start decompensating, they actually decompensate very quickly, and they die within a couple of years. So when they start decompensating, you have to increase their access to transplant, and that's why decompensated cirrhosis have very poor outcome. And so this is the same slide which Dr. Humar talked about. Living donor transplant is crucial and life-saving because you can bypass the liver allocation policy and changes, and can bypass lots of things, like you do not have to wait on the wait list, eliminates the wait time, has better outcomes, increases your access to transplant, and the mean MELD score for transplant is much higher in some of the regions as opposed to other regions, and you have the ability to optimize the recipient's health, and you can overrule the Share 35 policy. And given that in the era of organ scarcity and some of the issues with the organ allocation, this is one of the best methods which we should optimize. And there is also, Dr. Humar touched upon on the ABO incompatibility, which is a great utility for living donor. So this is the same thing which talks about 15 to 25% of the patients can die or succumb to their disease before we can get them to the transplant, and they lose the window of their opportunity. It's an elective surgery. You can optimize the donor and the recipient before transplant. They have great immunological advantages, lesser cold ischemic time, post-operative course is better, recovery time is better, so you actually have a better outcome. This means that one less person on the wait list for deceased donor. So this is just a quick slide to show despite the MELD, we know that the MELD is a predictor of mortality, but other than MELD, what are all the other predictors of mortality whom we should be thinking about liver transplant earlier on? Number one, we know serum sodium is already on the MELD. Other is if they have hepatitis C cirrhosis, liver failure, we already know that, listed in a small center, African American race, and MELD sodium we know predicts mortality. The delta MELD, which is very important, which shows that for any given MELD score, the change in the MELD score in the prior 30 days is more important than a MELD score at a given particular point in time. Ascites is a huge predictor. Hepatohydrothorax, which is when you accumulate fluid in your chest. Sarcopenia, which is muscle loss, frailty, and weakness and deconditioning, older age. Low albumin, patients listed in a status 1, which is like a fulminant liver failure patient, prior transplant. These are all the patients when you see, and you have to get them, if they are transplant candidates, get them to transplant soon. Indications for living donor and their evaluation. The potential recipient evaluation should not be any different than the deceased donor. The indications and contraindications are the same. However, some of the centers have adapted extended criteria for living donor. Like, for example, some centers have extended criteria for HCC, and some centers do acute alcoholic hepatitis outside of U.S., and so even in U.S., some centers, and for fulminant liver failure. So every center have their own extended criteria for living donor liver transplant, but depends on donor risk versus recipient survival benefit. So who are all the patients you refer for living donation? Patients on the wait list who are already listed, irrespective of their MELD sodium score, with a life-threatening complications or any signs of decompensation, should be referred for transplant for living donation. But usually the highest limit of MELD we like to keep is around 30. Dr. Humar can weigh in on that more, but only because the patients with a higher MELD score usually may have more portal hypertension, and all of those could, sometimes patients are much sicker, so you want the highest MELD to be around 30. But however, it doesn't work if you have liver failure. The MELD score doesn't matter in that area. And the biggest consortium of the study, which I'll talk about in a second, the living donor recipients in the A2All consortium had nearly 2/3 reduction in mortality with the living donor liver transplant compared to deceased donor. The median MELD score in that study was only 15, and so which shows that MELD score is not a useful indicator for useful indicator or predictor in all of the patients. It is a great predictor for many of the patients, but it doesn't work in this 25 to 30% of patients. Any patient with a MELD score of approximately 18 or higher, we should also think about living donation. Any patient who is sicker than their MELD can represent. That means, what do I mean by that? Any patients with a decompensation in the form of GA bleeding, varices, ascites, lower extremity edema, poor quality of life, encephalopathy, sarcopenia, frail, deconditioning, all of that, you think about referring them for, talk about living donation. Anybody on the wait list, think about that. So this is just general indications for liver transplant. I don't want to go through the whole list, but this is just something like liver failure, amyloidosis, inborn errors of metabolism. In some patients where HCC outside of the criteria, which what I mean by some centers have Milan criteria, some have UCSF criteria, some people have extended criteria. That depends on each and individual center. An extended criteria for living donation for HCC I'll talk about in a second. And malignancy is a great place for living donation, and cholangiocarcinoma and hepatoblastoma, some of those who do not meet the exact criteria or candidates also. And relative contraindications for liver transplant, we already know older age, organ failure, complicated surgical anatomy, functional status, and all of that, which I won't go in much detail. And absolute contraindications, we know that in patients with a fulminant liver failure, anyone with a cerebral edema, increased intracranial pressure, they are not candidates for transplant. Active infection, HIV with low CD4, extrahepatic malignancy, vascular and psychosocial problems. And so what does HCC, what are the advantages of HCC with a living donor? Living donation for HCC has been emerging solution only because there is increasing epidemic of HCC. Comparable outcomes with living donation with the deceased donor, even with the extended criteria from a lot of the studies from Asia. There is less waiting time, less dropout rate, and less operative risk, and overall survival benefit for the recipient. But depends on each center and how extended criteria depends on overall survival benefit and how much risk the donor wants to take, and the risk of tumor recurrence and biopsy size and the tumor burden in biology. And so advantages of living donor liver transplant for HCC, we just talked about, and it's a dedicated gift from the donor, so not competing with the other candidates on the wait list. And given that the time to recurrence in living donor liver transplant tend to be longer than in deceased donor liver transplant. Like I said, this is the graph. It shows that the patients with, So this is the graph. It shows that the patients who received transplant, living donation for HCC actually had a low probability of death as opposed to who did not receive liver transplant, living donor liver transplant. So the best outcome were the patients who actually received living donor for HCC. This is based on the A2All consortium study. So as I said, this is one of the other graphs which I showed that so the percentage of HCC, there is a huge epidemic of HCC because of the NASH epidemic and also with the hemochromatosis and hepatitis B, especially with the NASH, there is increased HCC. So as you can see, the number of patients with the HCC are going up. All right, so this is a graph. It shows that, so as you can see that there is an increased number of deceased donor in USA, but actually in Asian countries is actually the opposite. But yes, you can see the living donor is much higher in some of the Asian countries as opposed to US and other countries. In US, in USA, Germany, and UK, the living donor, and even in USA, the living donors is actually the opposite, because we only have 1 to 3% of our population get living donor surgery. So this is the A2All consortium, which I was talking about earlier. I'll just briefly touch upon on that. Okay. So total of 2,366 living donors, out of which 9 A2All centers, 67 non-A2All centers, but no difference in overall mortality between both the centers. But this is a study which shows that, so this is the study which compared the UNOS, A2All, and SRTR group, which shows that the outcome at 5 years exceeds 80 and 70% respectively. And you can see that compared to 98 to 2009, the graft survival has improved because of all the center experiences in the last several years. And the recipient outcome and the graft failure, the recipient mortality is based on the studies from the A2All, depends on the recipient age, the donor age, and the renal failure at the time, and the higher MELD sodium, and being hospitalized at the time of transplant, and longer cold ischemic time, and the experience of the center and the surgeon. They all played a role in the recipient outcomes. Okay, all right. So just to conclude, so living donor liver transplant is underutilized gift of life, and there is a substantial transplant patient survival benefit. And the biggest and the longest study was the A2All consortium, which I showed a 56% reduction in mortality, and which hazard ratio was 0.44, and anybody on the wait list who has any signs of decompensation should be talked about living donor transplant. And patients, especially with severe cholestatic liver disease and HCC, have the superior benefit. Living donor definitely has sustained mortality benefit, not only patients with a high MELD, but also with patients with a MELD sodium scores with less than 15 also, which I showed. So this is the same graph. It shows that there is a mortality benefit for sure. This is not including the HCC patients, but the living donor liver transplant patients have the best probability of survival with a MELD of less than 15 and a MELD of more than 15 also. So it is you identify the patients who are at risk for decompensation, and we talked about the predictors of mortality on the liver transplant list, and you have to increase their access to transplant and talk about living donation and and expedited transplant workup and getting them on the wait list and talking about liver transplant, living donation would be the best outcome for these people. And as we saw, there is an increasing waitlist mortality in low MELD patients, and they are at significant risk for death due to liver-related causes in the low MELD patients. And that is why it's very concerning. And that's all I have to say. And living donor transplant provides the best and better outcomes for such patients, including HCC. And all the transplant centers and surgeons and hepatologists should be more aggressive in identifying and listing these people and getting them access to transplant by means of living donor liver transplant. Thank you, everyone. Thanks a lot for your patience.
Thank you, Dr. Ganesh and also Dr. Humar. Before I turn it to Travis to moderate the questions, I just want to remind everybody where you can submit your questions for our speakers. On the bottom left-hand corner, you will find that blue icon. Just click on that and type in your question for the speaker. And while we have the question and answer session time, I will have this poll up. So for those of you who are listening in a group today, if you could be so kind to complete the poll, how many people are in your group, so that we can have an estimate on the attendance. I will turn it to Travis to start the question time.
Okay, I'll get it started here. So this question is, how common is altruistic living donor liver donation? For Dr. Humar.
So it's pretty uncommon. Altruistic donation altogether is uncommon and most commonly done with kidneys, which is for the donor anyways, a less involved procedure. But nonetheless, we certainly get altruistic donation, and more than just pure altruistic, especially for directed campaigns. So the situation that I'm talking about is that someone is in need, they identify, they don't have a suitable donor, but then they start a campaign, which is really either by social media or by the news media, and the word quickly spreads, and then someone steps up. They don't really know the recipient, so it's but they are willing to step forward, having heard their story. So it's not truly altruistic in the sense that it is altruistic, but it's altruistic directed, meaning that they're identifying a certain recipient, and that's much more common. I'll give you an example. We had a child recently that was in a foster home situation, needed a transplant. The foster group advertised it on, not advertised, had a plea on social media, and before long we had several hundred people that had called us inquiring about the child and whether they could be potentially donors. So a lot of powerful tools out there for finding a suitable donor.
Okay. So the next question is, how does your center increase awareness about living donor liver transplant? And I'll give that to Dr. Ganesh.
We have several ways of increasing awareness of living donation. The thing is that we truly believe that public is a part of that awareness. So we close the bridge between the public and us. So we use we have a very strong marketing team. So we use the public, we reach the public using the social media, the social hub, the Facebook, and we also contact the patients and the family. We also do some outreach and go to the referring physicians. So we use multiple ways to reach out to the public and both the patients and the family, and also to the referring physicians in several ways using the media and the social hub and the other ways. Because public is a huge part of this, and they need to understand, and like Dr. Humar mentioned earlier, that the referring physicians, including the gastroenterologist and the other hepatologists, have to understand also. So we try to close the bridge and educate them too.
Okay, thank you, Dr. Ganesh. The next question is for Dr. Humar. Can you please tell us about your experience with cases involving donor antibodies in the recipient?
So actually donor antibodies don't really have a lot of impact. It's unlike the kidney transplant situation where the presence of preformed antibodies have a significant impact on outcomes. Many centers actually don't even test for it, don't do cross matches. Now we do a cross match before a live donor transplant situation, and look for the presence of DSA in the recipient, but we don't alter doing the transplant. So the presence of DSA, the presence of a positive cross-match, is not a contraindication for us for the transplant, but we do alter slightly our immunosuppression management on those patients, are slightly more aggressive, and generally use steroids for a short period of time longer in those recipients. In our standard recipients, we only use 5 days of steroids generally, and then use a steroid-free regimen. And most of our recipients, we run fairly low TAC and MMF, and usually stop the MMF within 6 months to a year. That's our standard regimen. So for those with DSA, we generally do something a little bit more involved, but nonetheless, it doesn't represent a contraindication. We certainly don't pherese those recipients or use any other or use induction therapy other than an IL-2R in those patients.
Okay, thank you, Dr. Humar. Next question is for Dr. Ganesh. How do the outcomes of the recipient, particularly negative ones, affect the donor? Have there been any studies? What have you experienced in your practice? Or Dr. Humar?
Sure, I can take that. So obviously that has a very major negative impact on the donor when the recipient dies, especially when they die early. And certainly surveys that have been done looking at donor quality of life and donor outcomes, the ones that have had negative outcomes have have poorer results compared to those that have good results. And that's, I guess you would certainly expect that. Though it's still surprising, though, that even in those donors where the recipient outcome has been bad, even when it's an early bad outcome, even when you ask those donors, a year out from there, if you had to do it over again, would you do something different? And pretty much they almost uniformly say that they're still happy that they did what they could, and even though the outcome was bad, they're grateful that they gave that the team gave their recipient a chance, anyways. But nonetheless, you can imagine it has a significant detrimental impact on the donor. We make sure that we get our psychologists involved immediately and our independent living donor advocate involved immediately in those type of situations when they happen, and we bring the donors in for regular visits with them along with the surgical visits to make sure that they get counseling on grief counseling on top of their follow-up.
Okay. The next question is for Dr. Ganesh. Do you have a cutoff for BMI being too low for the donor?
So the BMI cutoff for the donor is usually we do not evaluate, like Dr. Humar said, if it is more than 33, and especially if there is fatty liver, we do not evaluate them and we want them to be around 30 to reduce any risk. There is increased risk of bleeding if the BMI is more than 30. But the BMI for the recipient less than 17 has shown like bad outcome. For the BMI cutoff for the donor per se for surgery, we do not we
don't have a lower limit, but generally we require that all donors are in good health, and so generally if they have a very low BMI, certainly anything below 20, then we'll put them through a more rigorous evaluation with nutritional parameters evaluation to see what their nutritional status is.
Okay. So the next question is for Dr. Ganesh. How soon should living donor liver transplant be discussed with those undergoing evaluation for a liver?
So it depends on how sick they are. Sometimes I discuss living donor liver transplant on my first visit. So irrespective of the MELD sodium, if they have any features of decompensation, their MELD sodium does not reflect how sick they are. We talked about it. So if they have any features of decompensation in the form of fatigue, poor quality of life, encephalopathy, ascites, lower extremity edema, bleeding, varices, or any of these decompensating features, then when you think about transplant, you think about living donor also, irrespective of the MELD. And as you know, especially in patients with a low MELD, these are all some of the predictors of poor outcome, and then you know that they're not going to get a liver for a long time, and especially if they are deconditioned and sarcopenic and frail, you want to talk about living donation earlier on in the process of evaluating them for transplant. So I'll have the discussion on day one when you think about transplant.
So my own feeling is that I just try to keep it as simple as possible, and I think living donor should be discussed with every single recipient at every single visit that they come in for. It's never too early to at least bring up the possibility to a patient to let them know that it's an option. Better for them to know about it early rather than scramble at the last minute, because finding a donor, discussing it, evaluating, all take a significant amount of time. So I think on the first visit, the second visit, the third visit, and every subsequent visit is when living donor transplant should be discussed with the potential recipient.
Perfect. Haiti, do we have time for one more question?
Yes, sure.
Perfect. So the next one would be for Dr. Humar. So how do you approach recipients who may be unwilling to approach family members, friends, church members about living donation?
So that's a very good question, because that's probably one of the major problems, or not problems, but major hurdles that we face, is that many recipients will say, yeah, doc, I know it's an option, but I'm not going to ask any of my kids to do this for me. I'm not going to ask anyone. And that, it's a difficult thing to overcome. And all you can do is really just inform them about it and ask that they bring family members into the evaluation process with them, so that at least the family can hear about it, and then they are not put in that awkward situation of having to ask the family. We also try to identify what we call a champion for the recipient. This is something that Hopkins started, where essentially it's someone who can act on the behest of the recipient to try to find them a donor, so the recipient is not put in that very awkward situation of having to ask family members, friends, listen, will you be a donor for me? Rather, they have a champion who says, look, my friend or my husband or my whoever needs a transplant. This is what a transplant involves. This is what the risks are. This is what the evaluation is like. This is what the recovery is like. If this is something you're interested in, please call the transplant center. And then it takes away at least a little bit from that awkwardness, but the awkwardness is definitely still there. And what you have to try to tell the recipient is that as their health is deteriorating, as they're getting sicker, and heaven forbid if they die while they're on the waiting list, all of that has a very negative impact on their loved ones, especially once they find out that they potentially could have done something to help them. So it's best to at least let people know of the options and let them decide rather than making the decision for them.
Okay. Looks like there's one more question in the queue. What are the concerns about coping for a donor donating to a sibling? And I'll open that to either Dr. Ganesh or Dr. Humar.
Donor the sibling?
The question was, what about concerns of coping with a donor donating to a sibling? So I think that the coping problem is the same regardless of who they're donating to, whether it's to a sibling or to anyone else. I think the key part of coping is that we identify a primary caregiver for the potential donor, someone who can be there for them afterwards, someone who can help them with appointments, someone who can help them with day-to-day chores, someone who can help them with day-to-day living and things like that. That someone who can be there for the donor after surgery, because certainly that's a time when they need it. And on top of that, then coping also means making sure that the center is involved in there. So we make sure that we see the donors on a very regular basis after the donation. We tell them that we are available 24/7, that they can call really literally any one of us at any time after if they have any concerns. We give them a number that they can reach us at. So those are the ways that you can do to help them cope through that very stressful time.
Fantastic. Thank you so much for such a thorough presentation. I think we all learned a lot today, and also for kindly answering all the questions. Thank you to all the participants for listening in today. We appreciate your time and hope you learned a lot today. And Travis, thank you for your moderation as well. I will move us, the speakers, back into the speaker room, and thank you all and wish you a wonderful day. Bye-bye.